One thing to be familiar with for the NBCOT exam is the spinal cord injuries and the clinical syndromes. We will review a little bit of the background, then the specifics of each syndrome and how they differ from each other. The clinical syndromes include central cord, Brown-Sequard, anterior cord, posterior cord, Cauda and Conus, and Cauda medullaris syndromes. As you watch the video for the first time, just appreciate the information as we review it. Then at the end of the video, I will go over some mnemonics to help you remember this. You can always rewatch certain parts later on. So welcome, you are watching the OTDUDE Academy NBCOT exam prep course. And if you're only watching this on YouTube, be sure to enroll in the free course to get the most out of the course. I'm Jeff, the OTDUDE, and let's get functional. The ASIA defines complete injuries as the absence of motor and sensory function below the level of injury. Instead, an incomplete injury spares some neurological functions below that level of injury. And most of the spinal cord syndromes that we will cover are considered the incomplete spinal cord injuries, such as central cord syndrome, Brown-Sequard, anterior cord, and posterior cord. Not included in the list are Cauda and Conus and Cauda medullaris, the ones that are named after their anatomical landmarks towards the bottom of the lower inferior part of the spinal cord. Clinical syndromes are considered a subset group of the broader spinal cord injuries. Central cord syndrome is characterized by a disproportionate motor impairment more in the upper extremities than the lower extremities. It is the most common of traumatic spinal cord injuries as well. Common etiologies include falls and motor vehicle accidents. For example, in older adults with underlying cervical spondylosis caused by a hyperextended neck, and younger people with trauma to the cervical spine. Central cord can also be due to non-traumatic causes as well. And with motor function more impaired than sensory, there is also bladder dysfunction. For most of the cases of central cord syndrome, most patients will experience considerable recovery without surgery. A predictor of a favorable prognosis includes hand function, early motor recovery, decreased spasticity, and a higher modified Barthel index score upon admission. You may encounter a patient with a central cord as well as other syndromes in settings from the ICU to acute care to acute rehab. They likely would have a lower GCS score. So one thing to note are precautions and watching out for lines such as central lines, catheters like the Swan's Gans catheter, blood pressure monitors, and other peripherals. Because of the mechanism of injury, a patient who is suspected of CCS should have been immobilized with a hard cervical collar such as the Philadelphia collar to prevent additional injury. Wearing times may also vary, but in general, hard cervical collars are typically worn for 6 weeks or until the neck pain is resolved, combined with neurological improvement. Traction may also be used to provide decompression, depending on the injury. For bed mobility, it's a safe bet to practice log rolls first. Research supports also early mobilization and rehabilitation for PT and OT once the patient is medically stable. For example, PT may work on gait and OT with hand function and functional activities that also involve ambulation at other times. The direction and progression of recovery usually begins in the lower extremities, then with improved bowel and bladder control, and then finally upper extremity function. So recovery moves from the inferior to superior direction. To remember this direction of recovery for central cord, think of the word cent in central cord. 1 cent is also known as a penny, right? And if you pick up a lucky penny, it is from the ground where your lower extremities are, and then you stand up to bring it to arm level. So the penny moves in the same direction as the recovery of CCS from inferior, where your feet are, to superiorly towards your arms. And to remember that central cord affects the upper extremities more than lower, think about the potential intervention of working on fine motor skills by practicing money manipulation in the hands with pennies. You don't really do rehab with pennies using the, feet. So that's one way you can remember it. Note that for some patients, upper extremities such as hand function does not recover. Evaluation should, of course, include assessment of the extremities compared to the lower extremities, especially of the hands. You should also assess for sensory deficits, temperature, pain. And with pain, you should keep in mind that there are different kinds of pain in general, and the cause of pain for central cord syndrome is likely to be neuropathic in nature, primarily anyways. Not musculoskeletal, but it could be complicated by musculoskeletal secondarily, but generally it would probably be neurological or neuropathic in nature for primary pain. Some patients may experience urinary retention and priapism, which is the prolonged duration of an erection due to upper motor neuron dysfunction. There is often also sacral sensation, as in it is spared, but there may be varying degrees of rectal tone. Other symptoms and complications include risks for respiratory compromise, cardiovascular complications such as orthostatic hypotension, which is common with SCI anyways, pressure injuries, autonomic dysreflexia, venous thromboembolism, and temperature dysregulation. And as an OT, you should be realistic in setting goals and giving hope, but also with an expectation that some patients may experience long-term functional impairments. In a rigorous study of CCS published in 2005, 81% of patients reported normal bowel function and 86% were able to independently ambulate. However, 59% experienced spasticity. So one thing to remember is that spasticity can be a major barrier to function, and it can exist with the syndrome and many other syndromes that we will go over too, actually. And so you can use the modified Ashworth scale as an outcome measure for spasticity. Note that also PAMs such as cryo and heat provide only short-term benefits for spasticity, but neuromuscular stimulation and functional e-stim have been shown to be effective for reducing spasticity as well as combination with medications. So yes, while you often learn about the upper versus lower extremity involvement for central cord holistically, the OT should address all the symptoms and play a role in the education and rehabilitation for the prevention and management of things such as pain, skin breakdown, comorbid conditions such as respiratory and cardiogenic in nature, also addressing spasticity, bowel and bladder function, falls, and my personal favorite, participation in meaningful occupations such as ADLs and leisure. And this includes education about the signs of autonomic dysreflexia, as there may be sensory involvement and even bowel and bladder dysfunction. But just so you know, that bottom-up approaches include hand strengthening, dexterity, and function, and splints that may be used to help prevent contractures. Top-down, maybe looking at more of the individual and trying to incorporate occupations. Brown-Sequard syndrome is characterized by a lesion that results in ipsilateral, same-sided motor and proprioceptive loss, as well as contralateral loss of sensitivity to pain and temperature below the level of lesion. Basically, one side of the spinal cord, say like the left or the right, is damaged. It is a rarer form of incomplete spinal cord injury and accounts for about 1 to 4% of the traumatic spinal cord injuries. The classic cause of Brown-Sequard is knife injury and trauma, but it can be caused by other trauma such as gunshot wounds, motor vehicle accidents, and blunt trauma, or even fractured vertebrae from a fall. It can also be caused internally, such as from disc herniation, tumors, and multiple sclerosis. Infections could also play a role and may be caused by tuberculosis, shingles, and meningitis. Historically, a Dr. Charles Brown-Sequard presented a case in 1862 involving a case of a captain who was stabbed in the neck, showing a hemisection of the spinal cord. Note the words hemisection. So while typically in the neck, trauma may occur at the thoracic level of the spinal cord and anywhere along it in between. One potential comorbidity along with Brown-Sequard is Horner's syndrome if the lesion is at or above T1. Horner's syndrome is characterized by ptosis or the drooping of the eyelid and other eye-related syndromes such as impaired pupil dilation. Again, there's weakness and paralysis on one side, hemisection, of the damage to the spinal cord and loss of pain and temperature sensation on the opposite contralateral side. Besides this, other symptoms include bowel and bladder dysfunction, respiratory dysfunction if the lesion is near the brainstem. The prognosis is good for ambulation of all the clinical syndromes, with about 75% to 90% actually being able to ambulate independently upon discharge from rehab. But the severity and potential of the symptoms depend on the part of the spinal cord affected and can range from mild to severe neurological deficit, not only for Brown-Sequard, but for just any SCI in general. But a good predictor of prognosis for Brown-Sequard is when the upper extremity is weaker than the lower extremity and the patient is more likely able to ambulate at discharge. In fact, Brown-Sequard is thought to have better outcomes than even central cord syndrome. Recovery time can really vary, like we kind of discussed, but it can take up to 2 years, and most patients will regain strength in their lower extremities, including ambulation or walking. Recovery is often faster on the contralateral side and slower on the ipsilateral side when initially motor function loss is present. Similar to central cord syndrome, cervical collars may be used depending on the level of injury, or even additional orthosis such as the halo vest, which has the thoracic involvement. Complications may include hypotension, spinal shock, pulmonary embolism, and infections. Precautions are all similar for spinal cord in general, but once again, these include watching the vital signs, respiration, especially if they are on ventilator support. OT evaluation includes ones that you're probably familiar with: MMT, sensory such as pain and temperature, proprioception, and discriminatory touch. Brown-Sequard shares many of the complications as central cord, such as autonomic dysreflexia and temperature dysregulation. Outcome measures you can use for ADLs are the Barthel Index and Functional Independence Measure, FIM. And more recently, the CARE tool is used instead. The OT would probably like to work with the patient on bed mobility, transfers, ADLs, and other occupations that may be affected. More specifically, after showers, the patient's skin should be kept dry and moisturized to prevent pressure injuries. The OT should also prevent muscle atrophy through strengthening, normalization of tone, and range of motion. Therapeutic breathing may also be appropriate for those with respiratory complications. Adaptive equipment may also be recommended if it is found to be beneficial. But overall, early mobilization for occupational participation is supported in the research, as well as preventing deconditioning, skin breakdown, and loss of function with upright tolerance and endurance. And don't forget to provide psychosocial support to the patient and to their families. And also educating on safety, such as if it is due to trauma, providing safety such as driving safety to prevent future injuries, as this really applies to spinal cord injuries in general too, right? Anterior cord syndrome is another incomplete lesion that affects the anterior 2/3 of the spinal cord, hence the name anterior. It is often due to flexion injuries and is characterized by motor function loss, as well as pain and temperature loss below the level of the lesion. But proprioception and light touch are often spared. So what you would expect to be normal are likely to be vibration sense, 2-point discrimination, and fine touch. This is because the functions are actually not supplied there in the spinal cord and are not affected by the anterior column, but instead the posterior column. And understanding that pathophysiologically, anterior cord syndrome is caused by the artery that supplies the anterior 2/3 being affected. And causes of this may be things like surgical repairs such as aortic surgery, hypotension from cardiac arrest, vasculitis, sickle cell, AV malformation, disc herniation, even cocaine use. Other symptoms are ones we have learned so far, including pain, autonomic dysfunction, hypotension, neurogenic bowel and bladder, and also sexual dysfunction. Patients may also have chronic pain and spasticity. Severity can also vary and may result in paraplegia or quadriplegia. Often the levels affected are from T1 to L2, so lower than the syndromes we learned earlier. Medical management may include drains such as in the lumbar, and so the precautions include watching for lines and peripherals when mobilizing patients and getting them out of bed. Also monitor for hypotension, bradycardia, and hypoxia. OT outcome measures for the interventions is going to be very similar and intuitive to the ones mentioned earlier. Barthel Index, FIM, Care Tool, and interventions in general to prevent immobility, pressure injuries, DVTs, pulmonary embolisms, and loss of function. Promote participation in meaningful functional activities such as ADLs, IADLs, and so on. Lifestyle changes include managing blood pressure, dyslipidemia, diabetes, and smoking cessation. Discharge planning should address barriers to function such as getting in and out of the house, showering, toileting, and so on in the real environment. Getting into even more of the rarer syndromes is posterior cord syndrome, PCS, which is only about 1% of the incomplete spinal cord injuries. Remember how in anterior cord syndrome, certain functions were spared due to the anatomy of the spinal cord? So intuitively, you already know that with posterior cord syndrome, what would be affected in terms of the characteristics compared to anterior cord syndrome, right? Well, because ACS spares proprioception and light touch, with PCS, it is characterized by the opposite: impaired proprioception, vibration, and 2-point discrimination, as well as deep touch below the level of injury. The lower body is often more affected. Pain is also possible, such as burning or tingling pain. The levels affected can be from cervical to thoracic, most commonly, but also down in the lumbar regions of the spinal cord. Causes include traumatic injuries, such as a hyperextension injury, such as from car accidents. Also tumors, degenerative disc disease, B12 deficiency, multiple sclerosis, and even untreated syphilis. And it may seem that these symptoms are not as significant, right, due to the loss of function compared to other syndromes earlier that may affect, say, motor function. But despite other preservations for PCS, the loss of proprioception can severely compromise things like mobility and self-care and other occupations. More specifically, patients may have poor balance and unsteady gait, putting them at risk for falls. And due to the impaired proprioceptive sense, patients may struggle in darker environments with certain movements and motions. Can you think of some OT interventions and adaptations and even environmental modifications for darker environments, not only indoors but also outdoors? I won't repeat the interventions for PCS. That is really kind of intuitive and similar to what we've been talking about before, but using the strengths and barriers to the patient's advantage. And now for arguably the best part of the video, I will mention how to remember the primary characteristics of the syndromes mentioned so far: central cord, Brown-Sequard, anterior cord, and posterior cord syndromes, and differentiating between them. When I studied these clinical syndromes, I make kind of like a chart to show the similarities and differences between them. For central cord, I mentioned the cent penny analogy. Another way you can remember central cord syndrome is that we often hear that OTs work with the hands and PDs work with the lower extremities or something like that along those lines. But we all know this is an overgeneralization and not true of what we do as OTs and PTs, but it is a common misconception. Anyways, think about the word central and the central focus between the upper and lower extremities. OTs would therefore work with the upper extremities. So with central cord syndrome, they would have more upper extremity involvement than lower extremity involvement. For us, OTs, to work with them on these things such as hand therapy. With Brown-Sequard, it's a little trickier to remember as there are contralateral and ipsilateral deficits to remember. But one thing you will notice is that in the table, there is a loss of all of the functions across the columns: motor, pain, temperature, proprioception, and light touch. And when you think about stroke, CVA, and the hemiparesis and loss of sensory function, it is on the opposite side contralaterally, right? Because of the crossing between the CNS and function. And let's say you had a left-sided stroke, it'll result in right-sided hemiparesis, sensory, dysfunction. So I like to think of Brown-Sequard syndrome as affecting the same side for motor and sensory, which includes light touch, in contrast to stroke, which is the opposite side. Then knowing that Brown-Sequard also affects pain and temperature, you can, by process of elimination, remember that it is therefore contralateral, because based on the pattern of how stroke is, it usually affects motor and sensory contralaterally. So therefore for Brown-Sequard, think of it as ipsilateral for motor and sensory, and all the other deficits would be contralateral. Another analogy that might help you remember this is during a brownout, like when the electricity goes out, or a brownout. And with Brown-Sequard, think of the word Sequard as sequestered, meaning isolated. So if you had a brownout and lived remotely in a location away from the city, and it was like very cold, your heater would not work, right? So you would all experience some pain from freezing and the cold. And it would be contralateral because you're on the opposite side of town compared to the city folks who all have their electricity and are not affected by the brownout. We kind of went over the anatomy of the spinal cord and why proprioception is spared in the anterior cord versus posterior cord syndromes, as well as for vibration for posterior. To remember the vibration part for posterior cord syndrome, you know how in those like souped up cars that have like a lot of bass and it makes like your windows rattle when they roll by and like vibrate? Well, that's caused by the subwoofers that are producing the bass, and the speakers are usually located in the trunk of the vehicle. So posterior vibration. Anterior would be for everything else in the front of the vehicle, such as anteriorly, such as the engine or motor, temperature controls for temperature sense, touch screen controls for light touch. And how about pain? Well, the driver of a truck, say, who is sitting anteriorly in the truck, may have back pain because they can't recline their seat for so long and they've just been really working hard. Really quickly, I want to review conus medullaris and cauda equina. The main difference between these syndromes is just really the location. With conus medullaris, it is anatomically higher as a sacral injury compared to cauda equina, which is lower below, such as L1 injury. Both of these are characterized by lower extremity motor and sensory loss, which makes sense as it's a low-level spinal cord lesion. And as you already likely know with spinal cord injuries, there's a high chance, especially of affecting bowel and bladder function. So there is that as well. You can remember this by just thinking of the two syndromes as just affecting the spinal cord at the lower levels and not overcomplicating things, and using your intuition based on the term and to understand both that motor and sensory are likely to be involved as well as bowel and bladder function. So not too bad. And to summarize, team goals and outcomes for spinal cord injury syndromes and spinal cord injuries in general really include the prevention of pressure injuries, independence with bowel and bladder function, decreased pain, increased patient knowledge about the disease, spasticity management, improving function, endurance, flexibility, strength, mobility, and bounce. You'll also want to educate yourself on lifestyle changes and prevention for further injuries and falls. Also DVTs, UTI prevention, and the management and prevention of autonomic dysreflexia. Don't forget to address the psychosocial. So referrals and support groups such as the Spinal Cord Injury Network, the Christopher Reeves Foundation are examples of further support that may be beneficial. So that's it for the clinical syndromes of spinal cord injury. If you found this video helpful, please give it a thumbs up and share it with your study groups. I'm Jeff, the OT Dude. Thanks for watching and good luck studying.